Okay, guys, so we might just go and get straight into it. So thank you to those that have dialed in today. My name is Amy and I am the Clinical Training Coordinator with the Point of Care team. And my background is nursing, nurse education. So a lot of my sessions do focus more on the clinical side of things and venipuncture, cannulation, and all those things that happen to affect our results that we see in point of care. So yeah, as you'll see, today is about the top 3 things that we do wrong, and this is more particularly in the clinical space that do affect our point of care results. There is a QR code here to register your attendance, as I've just spoke about, and on some of the slides even throughout it. If you miss it here, you will see down the bottom on some of the slides I've also popped it in where I can, just to give you ample opportunity if you did want to get this session recorded. Okay, so let's kick right off. So firstly, just an acknowledgement of country, so that just acknowledging the traditional custodians of the land on which we work and pay our respects to ancestors and elders past, present and emerging. I'm a proud Wiradjuri woman coming to you from Wiradjuri country today. Okay, so this one here, as I've said, it is covering I've narrowed down what I believe, and my colleagues might even argue with me on this one, or you guys might, so I'm open to feedback, but I've narrowed down what I see are the top 3 things that we can do wrong when we're dealing with handling and collection of our point of care samples. So today we're just going to cover a bit on collection in point of care, the pre-analytical errors in point of care, and how we can achieve better results. So the number 1 thing that I popped down, and this probably isn't a surprise to anybody, is poor collection techniques. So the number 1 thing that we do wrong is the way that we're collecting the sample. So the main things that we see, the main things that are, I guess, contributing to that really lousy result or that really lousy sample are when we're digging for veins. Now doesn't matter whether we're talking venipuncture or cannulation. A little bit of digging here and there is okay. No, let's not say it like that. A little bit of having to go to the left or the right if you feel like you've missed that vein isn't going to do that damage. I'm talking about when we're in that vein for quite an amount of time digging around trying to hit the spot. That's when that becomes a little bit of an issue. Excessive pulling on the syringe plunger, prolonged tourniquet use, collecting into plain syringes, using incorrect needles, and vigorous mixing. So if we go a little bit deeper into that, the first one I'll touch on is that digging for veins. And I wanted to show you, you may have seen this one before. It's a case study I have used previously, but this is a prime example of what digging for veins look like in a patient here, actually, in this facility at Gilgandra. And sorry, that's where I work. So as you can see here, this patient's potassium on the point of care device was significantly elevated on the number 1 sample there. And if we have a look at why, it was this right here. It was a collection from, and this was a 44-year-old woman. She came in, she's fit, she's healthy, she just had this sudden dizziness and vertigo, landed herself on an ED bed just for a general workup and whatnot. She's a thin woman. She was a little bit difficult to get blood from. So once they had that cannula in, they thought, well, fair enough, let's just grab our sample from that cannula. So they did a draw into a point of care syringe, but it was a hard draw. It was a little 20, what did we have, a little 22 gauge, I think, in her arm. And it still wasn't really giving up the blood. So it was a really slow leaking sample into the vein, out of the vein into the syringe. It took quite a while and quite a lot of effort to get this sample. And as a result, we got the result of 6.5. So what had happened there is obviously hemolysis, which you hear me bang on about all the time, and I will chat about a little bit later. The beauty of this patient was that the staff did recognise that their collection and that difficult collection may have impacted the result. So they were like, okie dokie, let's go again. We need to do a recollect here and make sure that potassium is actually as high as the isostat is saying it is. So they did another collection, and that's number 2 there, that still came back high, slightly better, but it was at 5.7. So this was a venipuncture collection. The issue with this guy was, again, it wasn't very easy. There was a little bit of digging around. It was a smaller butterfly. It was our little 23 gauger, and there was still, once they hit the vein, there was a fair bit of pulling on that syringe plunger to get that sample into the syringe. So it was better, but the staff were like, I'm still not convinced. This 5.7 isn't fitting the clinical picture. They'd done some ECGs as well. The ECG wasn't showing those classic changes you see with a hyperkalemic patient. So like, rightio, let's go again. This time, a 21 gauge butterfly straight into the vein. There were absolutely no issues. The blood flowed quite freely, and there we are. We produced a really good result of 4.1. So that's really, it's the best case I've come across to date of how digging for veins and difficult collections and hemolysis dramatically affect. Is that what I said? Hemolysis? Sorry guys, hemolysis dramatically affects your potassium result. The other interesting thing, which some people picked up on this case study when I first released it, was this right here. Whilst we solved the potassium issue, we then had a little bit of an issue with the troponin. We were suddenly then producing a false high troponin. So she came back at 0.18, again not fitting the clinical picture. Again, to the staff's credit, they questioned that result because it had been such a difficult collection, and 2, they questioned whether they had collected enough samples. So not only was it a tricky collection, they hadn't really got a sufficient sample. Again, recollect, and we saw a negative troponin. The next thing, so the excessive pulling on the syringe plunger. Look, I've been there as a clinician, and I'm sure you guys that take blood are sitting here nodding that you've sat on the end of a syringe, whether it be attached to an IVC or via venipuncture with a butterfly or whatnot. We've all had those veins that really don't want to give up the blood. So we sit there with the plunger and we pull quite excessively. We'll pull back and we'll let that blood slowly trickle out of the vein into our syringe. Sometimes if you're doing a really good job at pulling on that plunger, sometimes you'll even see that bubbling and that frothing of the blood. And yeah, it's not a great sample, and we'll talk about why. You've probably already guessed why, but just to highlight that one. Prolonged tourniquet use is another one, and I don't think we give this guy enough credit. And again, I've been someone who's popped the tourniquet on a patient, taken blood, walked away, come back, and 10 minutes later and realised the tourniquet's still on the patient. So tourniquets that are applied for too long can cause a really crappy sample. Again, it's generally hemolysis. So we need to start making sure that the first things first is we pop those tourniquets about 7 to 10 centimetres above where we intend to stab the patient. And we need to make sure that we are not leaving them on any longer than a minute. The other thing is, and we see this a lot again, we don't want to be asking our patient to vigorously pump their hands like this. A squeeze and hold is sufficient, and then a gentle release, maybe again, squeeze and hold, gentle release, but we don't want to see this vigorous fist pumping. If you have recognised that, hey, crap, I've left that tourniquet on a little bit too long, or maybe my patient's been doing this a little bit too excessively and you start to be uncomfortable with it, you need to take that tourniquet off, give the patient a 2-minute break, give those veins in that arm a 2-minute break, and then reapply your tourniquet and go and have another go. Collecting into plain syringes. If you've come to my other talks, you're not surprised that I've popped this in here. So fibrin strands, aka our microclots, are one of our biggest headaches in point of care. So in a non-heparinized plain syringe, which I'm guilty of it, and I'm sure there's plenty of you guys online that are guilty of it as well, of collecting 10 to 20 mils of blood and then just doing a decant and putting the blood where you need it. Unfortunately, we've only got 10 seconds when we use a plain non-heparinized syringe to get that blood where it needs to go before these microclots start to form. Point of care devices, they hate microclot. They're really sensitive to microclot, and we do see results impacted by it. So this is what I'm talking about. And this is where the next one, using incorrect needles, also kind of marries up and fits in as well. The one on the left, the needle into the formal pathology tube. Again, you're going to end up with a really crappy sample, as well as other health safety risks that I don't really need to go into for you guys. But the other one we see, and this surprises some people, but then other people nod and they know they're guilty of it, is when you decant into our point of care heparinized syringes from that big plain syringe. So obviously both of these methods, whether it's for formal pathology or point of care testing, it's a big no-no. Sometimes though, as you can see on this slide, I'm still saying no to point of care. Absolutely not. There's really no excuse to not be collecting into point of care heparinized syringes. There are still some incidences where you might collect into plain syringes for formal pathology, things like that. And the answer to that is to just make sure you use your your BD transfer device, so the guy with the red tip, and no needles. Needles, not only, again, did I say it was a safety risk, but it's also going to increase your risk of hemolysis again. So you're just trying to squish those red blood cells through far too small of a space, and that's where we end up seeing those falsely elevated potassiums. Vigorous mixing. I think we're getting much better at this. So I'm not going to touch too much on this, but it's just making sure that you practice gentle mixing. So your 10 figure eights, your 10 seconds of rolling between the palms, and not excessively shaking your syringe. This is just to make sure you're mixing that heparin thoroughly through that sample. So all of those that I just listed for you, yes, it does result in a hemolyzed sample. So that's one of our biggest issues. So by hemolyzed, for those guys who aren't 100% sure what a hemolyzed sample is, it is the destruction of your red blood cells. So I loved this picture, which is why I've used it. So that red blood cell gets broken open, particularly by all those things we do, and it releases all this extra potassium. So we have over 20% more potassium sitting inside those red blood cells than we do on the outside. So when we do all these poor techniques that break open the red blood cells, we release all that extra potassium, which we then collect into our syringe, and we start to see those falsely elevated potassium levels, which is a significant risk. We see a rise in the serum potassium, and then next minute you've got doctors ordering a stack of drugs to try and lower that patient's high potassium, which isn't actually high in the first place. I find that actually quite terrifying, and we've seen it happen. The other thing is these microclots that I spoke about before, and just remembering that the biggest culprit is your plain syringes. It's slow collections. It's giving that blood a chance to clot and form those microclots when you perform those slow collections. And it's also forgetting on your point of care to expel 2 drops of blood before each test that you run. Just remembering that the tip of that point of care syringe, it really doesn't have any heparin in it. So it's got a lot better chance, I guess, of forming those little microclots. So when you first get your sample, if you just get in a really good habit of dropping out 2 drops of blood before each test, you're significantly going to limit the chance of these little microclots forming. And where these guys run into trouble on that cartridge, which is why I've just included a cartridge for you, it's when they go over those sensors, and these little microclots kind of impact on the blood running smoothly over the sensors, and we do see some pretty inaccurate results. A big one is, again, your false high troponin. Okay, so moving on to number 2. So we've talked about number 1 being our poor collection. Number 2 for me is delay in testing. Delay in testing on your point of care devices can incur some pretty significant results. So the main ones that I see are troponin. If you have taken a while before you do run your troponin, we have seen some high troponins form. It's more that just being aware of it, thinking about the clinical picture of your patient, and if you have been distracted, maybe running other tests, maybe doing other clinical things for that patient, such as ECGs, monitoring, giving drugs, whatnot, it's very easy for 15 minutes to pass. So if that's happened, the best thing that you can do is just perform a recollect and retest that immediately. The next biggest delay in testing we have is on our gases. So it's when we, ideally we want, if your gas results are one of the top things that you're wanting to get from your patient, we really need to see you testing that syringe immediately to ensure that you get the best results for your patient. When you do get delayed, and we're talking delays are just like greater than 5 minutes. So if you're getting up towards that 10-minute mark, I'd be starting to get a bit worried. So when you get busy and you have that delay, you do start to see your pH go down, you start to see your PO2 go down, your glucose go down, and your CO2 go up, which ultimately, if you've got a respiratory patient or a patient that you're really keen to have accurate gases on, you've again got no choice but to do a recollect and then retest immediately. The reason that this happens is a lot of people are not aware that just because you pull that sample into the syringe doesn't mean that everything just stops then and there for a moment in time. Cellular metabolism continues once that sample is collected into your syringe. The other big guy that's affected on this is the lactate. And so the same rules applies with the gases. If you're really interested in the lactate result, well, you want to be getting that sample onto your device as soon as you can. If not, let's say 10 minutes has passed and then your lactate is high, you can start to question whether delay in testing might have impacted your results. And the other one that we see from delays in testing is changes in our hemoglobin. We actually get a lot of inquiries about this one where facilities contact us and say, hey, something's up with your device. It's reading me some crazy high hemoglobins, but then the lab's coming back completely normal. There's a noticeable difference. What is happening here is, again, a delay in testing. Staff have mixed the syringe usually pretty well. Maybe if they're working on an isostat, usually they run their gas cartridge first, so their CG4. They pop the syringe down, they go and get busy, they come back and they forget to pick that syringe up and remix it prior to the next test. What that's actually done is caused all those red blood cells to settle to the bottom of the syringe. So if the remix doesn't happen, when you go to place that sample on your device, it's going to receive that high concentration of your red blood cells. Now, there is a really simple way you can show this to staff that I've been using when I've been teaching this, and I just throw some glitter in a syringe. I'm just using a big 50ml here. Throw some glitter in the syringe. On the left-hand side, when it's all mixed, you can see the glitter is evenly dispersed. When I let it settle, that's what I'm seeing on the right-hand side, and that's my red blood cells settling. The only way you're really going to fix this is just remembering to remix immediately prior to each test you're going to run on your device. If you are a little bit worried, if you feel that a little bit too much time has passed, and I have had staff come and show me syringes where there's clear separation and the syringe looks a bit funky, you guessed it. I'm just going to ask you to go and perform a recollect and retest immediately. Okay, so the last one, number 3, it's incorrect sample type and requirements. So not fully understanding what your device requires and the type of sample that you need to collect. So some simple questions you can ask before each time you run your point of care is, do I have the correct sample size? Do I have the correct sample type? And what's the quality of my sample like? Did I struggle to get this sample that I'm holding in my hands right now? So again, if you've been and sat in my sessions before, you know that we're big on making sure we have enough sample. So if you're working on a 3ml point of care syringe, please start to get into the habit of a minimum 1.5 mils. Better still, we just want to see you fill them up. When they're underfilled, so when they're anything less than 1.5 on a 3ml or less than 1 mil on a 2 mil, I'm not sure what each facility is using in terms of syringe size, but when you put less than the minimum amount in that syringe, there's too much heparin in too small of a sample size, and we start to see some crazy results. Again, troponins really sensitive to this, and this is where you'll see your false high troponins. So make sure you've got the correct sample size. The next thing is to remember, have you got the right sample type? So having the incorrect sample type to test on your devices. So asking yourself, what type of sample does this device require? The first one I like to talk about is the INR. We have seen, and I can see how staff think in this way, but we've actually seen staff put a drop of blood from the point of care heparinized syringe onto the CoAguCheck, and it's just that heat of the moment and that and staff thinking, well, I've got a little bit of leftover blood in this syringe, 2 birds, 1 stone, might as well run my might as well get an INR on my patient as well, not fully comprehending that they've just put a, I guess, a blood sample that's coated in heparin on a device where you want a coagulation result. So for INR testing, just remembering that he needs a finger prick sample. He needs the first drop of blood and not to be used on snake bites. We're just using this for our warfarinized patients that we want an INR on. The next one that comes to mind is capillary samples. So if you're a facility that's running a capillary sample, just remembering that, yeah, that's a finger prick sample. For this guy, it's the second drop of blood, which can get a little bit of confusing for some people if you also are familiar with the CoAguCheck. But yeah, the devices want you to collect the second drop of blood for these samples, and that's just because when you first prick that patient's finger or bubby's heel or whatever your site location is, there is a little bit of tissue and interstitial fluid and things like that that are going to impact that sample, and by wiping away that first drop, you can kind of ensure that the next drop has got more blood in it. You want to make sure that you've got a full sampler, so you'll see there that I've got 2 different samplers there. Whatever the case, you need to make sure that you've got them full. And this is just your friendly reminder that if you are a facility that uses capillary sampling, that please do not use the Chem 8 cartridge. It's not validated on the Chem 8. And for venous and arterial sample, just remembering, well, this guy needs enough sample, at least half of the syringe size. He needs a point of care pre-heparinized syringe collected directly in, and a quality sample to ensure a quality result. So just to recap that, guys, the 3 things that I think we do wrong that impact our point of care results are: number 1, poor collection technique; number 2, delays in testing; and number 3, incorrect sample type or requirements being tested on the devices. So in a nutshell, what I want to say from here is just remember that a quality collection equals an accurate result, and a poor collection equals a risk of incorrect results. And also just remember to use your clinical critical thinking brains. This is just, by that way, you're just able to determine what results are most important to you for your patient right now, what are most urgent, what are the requirements on the device that you're working on, and how are you going to make that all work in together to make sure that A, your patient gets quality, appropriately timed care, but ensures that they also get quality, accurate results. I also just like to point out to people too, whether you're working from the lab or if you're working with point of care devices, is always remember that I understand we get busy. I understand that in the heat of the moment you just want the blood, but just remember with point of care that we don't have the luxury of the lab looking at our samples and picking up if we have hemolyzed it, or maybe if we have had a delay in testing that's affected the results, where they're not going to be there to pick those up. So in point of care, if you're using these devices, it's really pivotal that staff know how much their collection and their handling of samples can impact the results. And it's always going to be better to be able to pick those up, recollect, and do something about them, rather than going ahead and just treating a patient on that result that might not be accurate. That's about it. We've got a few more minutes, so I'll open it up to any questions. You can also email me or give me a buzz later if you prefer to have a bit of a chat about it. But does anybody have any questions before we say good afternoon? Seems like we're good, guys. Alrighty. If no one's got anything here for me now, I'll end this recording, and I hope you all have a good afternoon. Thank you.
Thanks very much, Amy.
No
Thanks,
worries.
Amy. See ya.
Thank you.
See ya.